Fantastic. So welcome everyone. Thank you very much for coming to the Leiomyosarcoma Support and Direct Research Foundation Conference today for London 2023. So this is the Foundation's 7th conference and the first actually since the COVID pandemic. And so we are really pleased that you are able to join us today. And we'd like to give a special thanks to our sponsor, PTC Therapeutics. So we have Mark and Emily who are sitting in the back. You want to put your hands up? Yay! Thank you. So please do have a chat with them and understand what therapeutics they have and just make them feel as welcome as possible. That would be absolutely fantastic. And then also would like to say thank you to our wonderful speakers for today and also for the venue for having us here today too. So the LMSDR Foundation now reaches its 17th year, which is fantastic, and we've seen it grow to become a leading foundation supporting those that deal with LMS on a day-to-day basis and pushing forward the boundaries of research with the aim of finding a cure. So my name is Maisie England and I will be the MC for today. I will do the introducing of the speakers and I've recently joined the LMSDR Foundation as one of their trustees. Sharon kindly invited me to be a trustee for the charity.
I snatched her up.
And so I found that I had LMS in my ascending colon earlier this year. And so even though it's not a club that I imagine anyone else in the room wants to be a part of, I'm really glad that we have this group and the support that it has given. So just before we begin, a bit of housekeeping. So in terms of emergencies, so today there are no emergency evacuations planned. However, in the event of an emergency, we follow the green signs and the meeting area is in the car park out the front of the building. And then throughout the day we have tea and coffee breaks planned, and that will be down in the tea and coffee location that you came into earlier. If for any reason you might need a break during any point of the day, please do feel free. So there is, you can go out that way or you can go out through the back. And in terms of toilets, so that there is also a toilet at the back here and it's up the stairs, and there's also a disabled toilet, an easily accessible toilet just down the front there too. So during the sessions, we will be recording the speakers and the questions and answers for our use. So it will mainly be focused on the speakers, and so you shouldn't really see your faces. However, if you are uncomfortable with us recording, please do let us know and we'll make sure that we definitely can't see your face in anything. So as mentioned, we will have questions and answers sessions at the end of each presentation. So if you could refrain from asking your questions until the end of the presentations, then that would be great. I know Professor Jones was really keen to have more sort of interactive sessions, so please do ask your questions as they go. As mentioned again, if you don't want to be recorded, even your voice, then please do let one of the organising team know so that then we can write down your question and ask your question for you on your behalf. So then just on to the organising team. So we have Sharon and myself, but we also have Dondi. Do you want to raise your hand? And also Susie here. Susie's just down the front here. So again, if you don't want to be recorded, then please do let us know. And if you have any other questions during the day, then also please do ask. So the schedule for today, so we've got a wonderful schedule for today. So we've got everything you need to know about LMS, interventional radiology, research on LMS, new trials, treatments, anxiety management, and EFT tapping. So it's going to be a wonderful schedule for the day, but we have planned in tea and coffee breaks during the time. Be absolutely brilliant if during those times you can, get the opportunity to chat, meet other people, and also ask some of the speakers some other questions that might come up throughout the day. So, I'm going to start off with our very own president, the LMSDR Foundation, Sharon Anderson, to give you a warm welcome and to give some key highlights of the foundation this year. So, the foundation was founded by Suzanne Kurtz, Sharon's close friend, in 2006. And since then, Sharon's been an integral part of the foundation, continues to be a huge driving force behind it. So Sharon herself is a ULMS survivor of 21 years, which is fantastic, and understands well what our friends here have been going through. So in 2005, she successfully co-managed the patient tissue donation campaign, and she's conducted many follow-up interviews, and also she's just been a huge driving force behind a lot of the work that LMSDR have been doing, even testifying at federal government as part of the Morcellation campaign. So working in social work, Sharon is a great people person and someone we all know and trust, and our amazing advocate for LMS support and research. Her commitment really is astounding, and we thank you very much for everything you do, Sharon.
Thank you.
So just a little bit of trivia. She likes her morning coffee. I believe she has had a coffee this morning already.
Yes, I'm good.
And plans to learn how to Irish dance this year.
Yes.
So without further
Very soon.
ado, please, Sharon.
All right, thank you very much. I have to say this. Hello. Well, she took care of a lot of the introductions, but as you know, I'm a 21-year survivor, and I've been there. I've been there through the very first year of being diagnosed to trying to advocate as much as we can and hold each other's hands along the way. So I'm very happy to be here. This is our 8th conference and our first one in the UK, and I hope not the last one. So LMSDR, no, it's not going to go. There we go. LMSDR started in 2005 when Suzanne Kurtz, a dear friend with LMS, and I started going to the CTOS sarcoma conferences. And I would come back year after year crying because there was nothing on LMS, nothing. There was a lot of other sarcoma research going on, especially with GIST, you might have heard of that, but nothing with LMS. And so Suzanne finally got fed up with me, and she said, Sharon, if you want to do something, you have to work for it, not wish for it. And that became our logo, working, not wishing. And so we have done. So I believe, let me read this slide here. I'm going the wrong direction. So our mission is to empower patients with information and support. We do that through our support group, and we do that with our newsletter. We do webinars and the conferences. We fund groundbreaking research. You could look on our website and see all the grants that we've made and what for, and some of the findings that have come out of that research. The great thing about it was there was not a lot of research when we began on LMS, and now there is a lot more. So we're very happy to be part of that. Our mission is to provide a bridge between patients and researchers to collaborate on finding a cure. And I think that is really crucial about LMSDR. We like to collaborate with the researchers directly. We'll be going from here to the CTOS conference to talk to researchers about their interests in research and see if they want to research LMS and how we can collaborate together. In 2005, we started a patient-led tissue bank drive where we collected from patients 500 tissue samples, which was the biggest collection at that time. And since then, that collection has gone around to different researchers, and they've done research on it, so we're really happy. And right now, we're collaborating with Count Me In. And we want to get that over here. Count Me In. That's a goal of ours, yeah. I want to thank our sponsors once more, PTC, Emily and Mark, and UK Sarcoma UK, I should say, for their booklets that they gave us today. Where are they? There they are in the blue. You can't miss them. Thank you for coming. And they have a 108, I call it 100-800 line, because in the U.S. that's what a free line is called. But they have a lifeline that you can call and get advice from them. So that's a good thing to do. And of course, I want to thank our special guest speakers. And a special thanks to you all for coming. So I want to get to know you a little bit. So
I'm just going to quickly introduce Professor Jones and Dr. Hatapoulou. That's right. So just before we begin, Professor Jones is the team leader at sarcoma in sarcoma clinical trials at the Institute of Cancer Research and consultant medical oncologist at the Royal Marsden. He specialises in treatment in bone and soft tissue sarcomas, focusing on developing novel therapies for these diseases. He has experience in conducting phase 1, 2 and 3 trials, as well as translational studies in sarcomas. So between 2010 and 2014, he actually lived on the other side of the pond and was head of sarcoma program for the University of Washington and Fred Hutchinson Cancer Research Center in Seattle. He started his training off at Guy's and St. Thomas Hospital, I believe, and his medical oncology training here at the Royal Marsden. So he is a consultant oncologist and reader at the Royal Marsden and Institute for Cancer Research, and is currently working on a number of trials in sarcoma, as well as lab studies with Dr. Paul Huang, who we'll also hear from a bit later. So Professor Jones is very well known to many of us with LMS, and on a day-to-day basis he's an extremely busy clinician, providing support and care to his patients. So once again, thank you so much. And Dr. Emin Hatapoulou is a cancer research clinical research fellow at UCL's Cancer Institute and a medical oncology registrar at the Royal Marsden Hospital here also. Having studied at King's College and Oxford, she built up an extensive experience in other NHS hospitals too. She's incredibly busy academically and has led and co-led over 21 papers in areas related to antibodies and T cells. So, for example, new immunotherapy insights into cancer, kidney cancer, to help us understand why immunotherapy sometimes works, sometimes doesn't, and the role of T cells to increase the chance of the effective treatment. So I've talked long enough now, so just please welcome Robin.
So thank you, Macy, for that really kind introduction, and it's really nice to see everybody, a lot of familiar faces in the audience. Really nice to see Susie and Sharon. And Sharon and I have not seen each other for 10 years.
10 years.
San Francisco.
Yes.
Yeah. And you look just the same. I think my hair is much whiter. But as I say, it's really, really nice to see everybody. I've got a number of slides. I think this is a tough act to follow, so I think my slides are going to be very boring after that. But I'd really like if you just ask M&A and I questions at the end. So it's just to give you an overview and some underlying principles. And as I say, I'd really like to just open this up to questions and discussion. I think that's much more informative. Got it. So I think the major thing, as with all sarcomas, that they're a collection of different diseases, and even though we classify leiomyosarcoma as one disease, essentially I think it's many, many different diseases. And we're still sort of scratching the surface, really, in terms of trying to understand the underlying biology of these different types of cancer. And in a sort of simplistic way, we already know that there are different anatomic variants of leiomyosarcomas. So uterine leiomyosarcoma, retroperitoneal leiomyosarcoma. Leiomyosarcomas can arise in the arms and the legs, they can arise in the heart, they can even arise in the bone. So there are clearly different diseases there, and even these anatomic variants have slightly different clinical characteristics and response to systemic therapy. Matt van der Rijn and his colleagues in Stanford have done a lot of work trying to understand the biology of these diseases and have split them into molecular subgroups. But again, I think we're really just at the surface of trying to understand leiomyosarcomas as a spectrum, as a family of cancers. And in terms of the anatomic variants, it's clear that there are different prognosis depending on the anatomic primary sites. So a leiomyosarcoma rising in the heart, it's obviously a very, very challenging anatomical location, very challenging to remove all of the tumour, whereas a leiomyosarcoma rising in the skin can easily be removed, and the prognosis is usually very, very good. And for sarcomas in general, the extremities are the main primary sites, lower limb accounting for about 40%, upper about 20%, and then the abdomen accounts for about 20% as well. But as I mentioned, leiomyosarcomas can occur elsewhere, so in the trunk about 10%, and also in the head and neck. And in terms of the diagnosis, obviously it's very important to get the correct diagnosis, and the major thing is to perform a biopsy, and we usually do this under radiological guidance, and it's a pleasure to have Ed Johnson with us today, who'll talk a little bit more about this and also about interventional radiology techniques. But the crucial thing is that the biopsy tract is removed in its entirety at the time of surgery. And this is a picture of a core biopsy. We usually, of course, do a clinical examination and also an MRI, particularly for leiomyosarcomas arising in the arms and legs. And as I mentioned, ideally the biopsy tract should be in the direction of the future surgical resection of the tumour. And the aim of treatment in terms of removing a leiomyosarcoma from the limb in particular is to preserve function and to try and remove the tumour in its entirety with a rim of surrounding tissue. Amputation is rarely necessary, and for high-grade tumours we usually give pre- or post-operative radiation as well. And there are really good trials to clearly show that radiation is helpful in terms of decreasing local recurrence in tumours of the trunk and limbs. But one of the major things with sarcomas, and Sharon mentioned the fact that a lot of gynecological surgeons were performing morcellations, is inappropriate diagnosis and intervention. Somebody sees a doctor sees a lump and thinks, well, we'll just remove it. But with sarcomas, it's really important to know what the diagnosis is ahead of treatment, and it's really important that a biopsy is performed so that we can plan out what the treatment should be. And this is an old slide from one of the surgeons who used to work at the Royal Marsden, which Sam Hackett knows really, really well. So basically, the fact that sometimes a surgeon just sees a lump and then just removes it without actually thinking, well, what is this? Do I need to do a biopsy and plan out the treatment? And I think this fits in with the role of the multidisciplinary team and the fact that patients with sarcomas should be managed by a full experienced team of doctors that are familiar with these tumours and know how to treat them. And over the years, there have been a number of studies showing that referral to a sarcoma team can have a huge impact on outcome. And these studies go back a number of years, back to the 1980s even. But recently, the French sarcoma group have performed a really huge retrospective study of patients treated all over France. And the bottom line is they've shown that the patients referred to a sarcoma centre for initial surgery have a significantly better prognosis than patients treated elsewhere. And I think this is a really, really important slide in terms of the fact that, you know, early diagnosis is important and management by a dedicated sarcoma team is essential. The role of pre or post-operative chemotherapy in a lot of sarcomas remains fairly controversial. There's a lot of, always a lot of heated discussion about this topic, and Sharon and Susie will know from previous CTOS meetings that this is always a fairly inflammatory topic with really, really strong views on either side. The true answer is probably somewhere in the middle, as always, but I think there is now more evidence, even though it's sort of indirect, that pre or post-operative chemotherapy is helpful for certain patients with high-grade tumours. I'd say that the UK is probably still on the sort of anti-chemotherapy side of the fence, whereas a lot of other European countries have gone over to proposing post-operative chemotherapy for many patients. As I mentioned, surgical resection is clearly the mainstay of management with or without radiation. There have been trials of using post-operative radiation in other types of leiomyosarcomas in other locations. The EORTC sarcoma group did a trial of post-operative radiation in uterine sarcomas, and essentially this trial did not show a benefit for using adjuvant radiation in uterine leiomyosarcoma. In terms of neoadjuvant chemotherapy, as I mentioned, there are a number of trials, a number of studies that have suggested that there is a role for neoadjuvant preoperative chemotherapy in high-risk sarcomas, so sarcomas that are over 5 centimetres, sarcomas that are high-grade, and sarcomas that are deeply seated in the body. And one of the sort of major trials that have proposed this is this trial from the Italian sarcoma group, which basically randomized people to have preoperative chemotherapy with either standard anthracycline or ifosfamide, or chemotherapy tailored to that particular subtype of sarcoma. And leiomyosarcoma was one of the subtypes included in this trial. Somebody asked me, why do I always do that? Because I'm paranoid about the clicker working. So I think this is a really, really important trial. I won't go into the sort of the detail of this, but we can talk about this later if anybody's interested. That they basically, as I said, allocated people to receive one of two types of chemotherapy, so the standard treatment or the histology-tailored treatment. And as I mentioned, leiomyosarcoma was one of the groups. And in their initial analysis, they showed a benefit for the standard chemotherapy in terms of relapse-free survival, so the length of time that it took for the cancer to come back, but also in terms of overall survival. So
so fast. You're going so fast.
Oh, okay. Yeah, I'll slow down. Yeah. So this is the time from treatment to the cancer coming back, and the top curve is the standard chemotherapy arm. So those people do better than those treated with the histology tailored preoperative treatment. So that was an indication that maybe the standard chemotherapy can help people with high-risk leiomyosarcomas that are over 5 centimetres and that are of high grade. And similarly, for overall survival, the trial showed that there was a benefit for the standard chemotherapy. One of the criticisms of this trial is that it hasn't answered the question, well, what if patients just went on to have surgery directly rather than having chemotherapy. And I think it would be very difficult to do a trial like that now because of the fact that chemotherapy is used as a standard by a lot of centres around the world. But again, this is a very controversial topic and a very good topic to open up for discussion. For leiomyosarcomas in particular, there was an attempt to perform a trial of using post-operative chemotherapy in uterine leiomyosarcoma, but the bottom line with this is that it failed to complete recruitment. So for 5 or 6 years it was open, but it was very difficult to recruit patients into this trial. And there may be a bias in terms of the opinions of the doctors treating patients, that some doctors feel that chemotherapy works, other doctors feel that chemotherapy doesn't help, and that the doctors would recommend patients to have a specific treatment outside of the clinical trial. So this is this is important because we were not able to complete recruitment into this trial to answer this question. And of course, for leiomyosarcomas arising in the abdomen, there's an ongoing trial with the EORTC, so looking at preoperative chemotherapy in both lipo and leiomyosarcomas arising in the abdomen. So this trial, people are allocated to either receive chemotherapy followed by surgery or surgery alone, again to try and directly answer the question whether chemotherapy helps for leiomyosarcomas in this anatomic location. So with that, I've finished. But as I say, it'd be really good to open up for questions and discussions.
So I want to say, I think in the States, should I have a microphone? I think in the States, the thinking is more that adjuvant chemotherapy is not helpful, or does it show a benefit?
Hello? Oh.
Oh, there, okay. And that they'd rather have a tumor to measure when they do chemotherapy, because a lot of our chemotherapies are not very, very useful. I mean, the percentage of response rate is not that big, so.
So I think that's a good point. I think there's a fair bit of variation in the US between different centres. So I think certain centres are very sort of strong supporters of giving pre or post-operative chemotherapy, whereas other centres may not be so supportive. But I think the good thing about giving pre-operative chemotherapy is that you can actually see what's happening with the tumour, whether it's shrinking or not. Whereas if you give it after the operation, you can't really say whether the chemotherapy is actually doing what it's meant to do. And of course, all of these chemotherapy drugs have side effects. Some of the side effects can be long-term. So in general, certainly in the UK, we would tend to use chemotherapy before surgery, just to see. Yeah.
Would you use that at stage 1, for instance, even though, would you use that chemotherapy at stage 1 today? It wasn't used before, but would it be used at stage 1 then, from what you're suggesting?
So, so the question was, would you use chemotherapy post-operatively for stage 1?
For stage 1, yeah.
So the staging of sarcomas is really challenging, and the most recent staging system uses different staging systems, or different classification systems for different parts of the body. In general, in the UK, we would use preoperative chemotherapy if a tumour was in the arms, legs, trunk, if it was over 5 centimetres, if it was a high-grade tumour, quite aggressive, and if it was deep inside the body. So it wouldn't depend on the stage so much as those particular features of the tumour and the type of sarcoma as well. So leiomyosarcoma, synovial sarcoma, pleomorphic sarcoma, myxoid liposarcoma.
Right, okay. Is just I had uterine sarcoma. They weren't offering at the time, and you were saying there it doesn't. You don't know yourself whether that would be advantageous or not.
Exactly, and I because that randomised trial did not recruit enough people, I don't think we'll ever really have an answer to that. But there are very strong opinions about the topic of giving post-operative chemotherapy for uterine leiomyosarcoma in particular. And
I think very much when I was diagnosed, it's been a long time now, but we were with the Americans on that. So we just, because they had more experience than we did back when I had my cancer. So there wasn't anything for LMS anyway. Not that I'm unhappy with that, but it was always, if it comes back, then we'll do the chemo then. So I always relied on the American information at the time.
I as I say, I think there's still a lot of debate about this, and I think in the UK we have a tendency to be more conservative about the use of post-operative chemotherapy. My colleague Andrea, who is from Italy, tends to be more sort of the sort of Italian, French, Spanish viewpoint that, you know, in certain instances chemotherapy is useful. And I think even though we haven't got a concrete randomised trial to show that, you know, chemotherapy versus no chemotherapy in terms of chemotherapy improving the outcome of people, there is indirect evidence that it is helpful. But it's a very difficult, you know, balancing act because there isn't clear evidence base. For other cancers, breast cancer and lung cancer, for instance, you know, it's been possible to do large randomised trials, and, you know, there's a clear evidence base. But here it's a little bit harder to, you know, to perform a trial and to make sure that the trial is meaningful in terms of including patients with a specific type of sarcoma, high grade, greater than 5 centimetres. So, yeah. You ask questions rather than me just talking. That's,
Question. Does it depend on how...
Can I just double check? Do you prefer to have
Hello.
questions now, or would you prefer for M&A to do a bit of the presentation, we ask the questions together?
Maybe we can just finish this question and then...
I just wonder, does it depend on what grade?
Do you want to move it across a bit so your face isn't in the light?
Oh, sorry.
You had slides on your face, so that was why I was just thinking that.
No, maybe I'll move over here.
Then you're not blinded. Blinded by the light.
No, I can see all of you quite well. But,
Okay, I just wonder, does it depend on what grade the tumor is, how well it responds to chemotherapy?
So in terms of pre or post-operative chemotherapy, we would tend to use that for higher grade, more aggressive tumours. For lower grade tumours, we wouldn't want to risk the side effects of chemotherapy because grade is a factor in terms of the tumour coming back. So the higher grade a tumour is, the more chance of the tumour coming back. And for that reason, the aim would be to give chemotherapy to kill the cancer cells that may be floating around in the blood to prevent the cancer from coming back.
Okay, so it doesn't depend on how fast the tumor is developing. It's more like the risk of it returning.
So I think in terms of the rationale for using chemotherapy, it's the risk of it coming back because we want to decrease that risk. Usually for faster growing tumours, chemotherapy tends to work better, but I'd say that isn't an absolute, that, you know, sometimes if the tumour is high grade, it doesn't necessarily mean that chemotherapy will work. So the rationale is to decrease that risk of the cancer coming back for higher grade, worse, bad tumours, if that makes sense. Yeah, no, thank you. Sorry for going through the slides too quickly.
It was too fast. Is there any way for us to be able to get access to those
Yes, of course.
slides?
Yeah.
So I think after today, Sharon, is this right? We're going to let colleagues have, let friends here have the slides. Is that right?
If the doctors are willing to do that.
Yeah.
And this is being recorded too, so that's helpful.
Yeah, that's right.
As I say, I'd much prefer the discussion rather than me just talking. So I'd much prefer if you ask questions. Then.
Okay.
So should we continue with M&A and then we'll continue with questions? Is that okay?
Yeah.
Hi everyone, thank you for letting me talk today. Very nice to meet you all. So I'm going to talk to you about the advanced disease, so for like the metastatic setting.
Can you speak up a little more?
Yeah, sorry, can you hear me better now? So I'll focus on, oops, going the wrong way. There we go. So can you hear me okay?
If you put the microphone with the coffee cup.
Yeah, maybe 1 second.
There we go.
Better? No? Okay. I'll try to speak up. So for metastatic disease, there are different treatment options, which is kind of dependent on the specific situation for the patient. We can offer symptomatic control with no intervention. We can consider more local regional therapies with ablations, embolizations, radiotherapy. In some situations, even surgery could be considered. But today I want to talk about systemic therapy, i.e. chemotherapy, and immunotherapy. In the metastatic setting, the key chemotherapy for leiomyosarcoma is doxorubicin, and there has been several trials over the years which looked at combining doxorubicin with other chemotherapies to see if it will change outcome, meaning the overall survival or the time to disease progression. Unfortunately, the trials have been negative, meaning that doxorubicin remains the standard of care treatment in the first line for metastatic leiomyosarcoma. Since then, we've looked at combination of other therapies with doxorubicin. One of them is olaratumab, which is a antibody that targets the PGFR receptor, and it was given in combination with doxorubicin in one arm in this trial, and the second arm doxorubicin was combined with a placebo, and unfortunately the trial was negative. There was no benefit of adding the antibody to doxorubicin. So when patients unfortunately progress on doxorubicin, there are other chemotherapies we can offer during that journey. And now I'd like to talk a little bit more about those treatments. So over the years, there's been a lot of trials, which I will not go through in detail, where we've looked at combining different treatment options, chemotherapies with doxorubicin or without doxorubicin, to see if we can get some benefit for patients who progress on first-line treatment for metastatic leiomyosarcoma. And this is just the list to show, there's been a lot of study on that. One of those drugs was ifosfamide, which is another type of chemotherapy, where we looked at role of ifosfamide in metastatic leiomyosarcoma patients in the first-line setting, and unfortunately, it was inferior compared to doxorubicin. And pazopanib, so the palette trial looked at pazopanib, which is a tyrosine kinase inhibitor. So it's a drug that specifically targets a receptor. And in this trial, we looked at patients who have progressed on doxorubicin, and in one arm, patients were given pazopanib, and in the other arm, they were given placebo. And there was a benefit in terms of the disease, time to disease progressing, but there was no benefit in terms of the overall survival. And trabectedin is another key chemotherapy for leiomyosarcoma. So it is an interesting one because chemotherapy, although they kind of use different mechanisms, they usually just target rapidly dividing cells, and they target these like cell division pathways. But trabectedin is interesting in the sense that although it does that, it was also shown to have a impact on the immune system, especially the macrophages, and decrease inflammatory mediators within the tumor microenvironment. And there's been, again, a lot of interest in trabectedin over the years, and there were several trials where trabectedin was compared to either best supportive care or different chemotherapies to see if it would add any benefit in the metastatic LMS patients. And here, trabectedin was compared to dacarbazine, which is another chemotherapy, and the trial showed that there was a significant benefit in terms of progression-free survival. So in terms of the disease progressing, trabectedin was much better compared to dacarbazine. And again, you know, I don't want to go through these specific trials in a lot of detail, but again, as we progress through the lines, gemcitabine is another chemotherapy where it was shown to be more effective when it was combined with docetaxel compared to using gemcitabine alone. There was a benefit in terms of both the disease progressing and also the overall survival. And here on A and C, you can see this is so the graphs are split based on the performance status, so how fit the patients were, and you can see that in all settings the combination chemotherapy was more effective compared to giving gemcitabine alone. And again, this is combining gemcitabine with another chemotherapy called dacarbazine, and again, the combination chemotherapy was more effective in terms of overall survival. And eribulin, another type of chemotherapy where it was compared with dacarbazine, and we've seen that eribulin was more beneficial in terms of overall survival compared to dacarbazine. But what I think the bottom line, the numbers and the trials are a little bit irrelevant in a way, because what I'm trying to really get to in this, with all these slides, is that, you know, there are lots of trials that we've done, there are lots of chemotherapies we've looked at, and yes, with some of them when we combine treatment, we have seen benefits. But actually, if you look at the months, the benefit we're getting, yes, it's good and it's better than not having any benefit, but it just shows there's still a lot of things that we should be doing to get more benefit, to kind of get the benefit in the metastatic setting that we have for other types of cancers like breast cancer, like lung cancer. So it just highlights, yes, there has been success and it's positive, but actually it's not really enough. And immune landscape. So we know from, I think, media, from the scientific papers, that immunotherapy has revolutionized cancer treatment. So it started off with melanoma, which was a disease with very poor prognosis, and now you can get patients cured from it even in the metastatic setting, and that was all because of immunotherapy. Initially with ipilimumab, which is a CTLA-4 inhibitor, and then anti-PD-1 treatment. But how about in sarcoma? So what do we know? Has it worked? So I'm just going to use this slide as an example, or as a representative slide. So there has been several trials in sarcoma, in soft tissue sarcomas, and these trials have included patients with leiomyosarcoma. Unfortunately, the trials have been negative, as in they haven't shown any benefit. So this specific trial, SARC-28, they've looked at benefit from pembrolizumab in patients who had advanced sarcoma, and here you can see they had 10 leiomyosarcoma patients. And essentially, I mean, there wasn't any kind of significant benefit in terms of survival or disease progression. And here, this is just another representation. So they've seen, they looked at leiomyosarcoma, undifferentiated pleomorphic sarcoma, and the lines going up here, I don't know if I can use a pointer, but the tumor size continued to get bigger even with the immunotherapy treatment. So I think, and then there was another trial with nivolumab, which was negative. It was a phase 2 trial. So then I think the question is, why does it work in lung cancer, and why does it work in melanoma, but why has it continuously failed in sarcoma, in leiomyosarcoma? So I think the question comes down to, well, do we know enough about the immune landscape in leiomyosarcoma? And if so, what do we know so far? And that's what I want to talk about a little bit. So there has been several studies, although it's been quite limited until now, to understand the immune landscape in sarcoma, including leiomyosarcoma. So Professor Jones and his colleagues have done a study in 2017 where they looked at the gene expression profile and immunohistochemistry to look at the immune cell infiltration in sarcoma tissue from sarcoma patients. And here, so the LMS, I don't know how much you can see this, but yeah. So you can see that, so for example, CD3 is infiltration of like T cells in general. And you can see actually compared to other tumor types, it does have a reasonable T cell infiltration. It does have a reasonable expression of PD-L1, which is a protein that's expressed on the tumor and also on immune cells. CD163 and CD86, these are different types of immune cells called macrophages. And you can see that actually, especially CD86, it has a quite reasonable and maybe higher expression or infiltration level compared to other sarcoma subtypes. And this is just a slide to show the staining of what they've looked. So they looked at gene expression, then they confirmed their findings on immunohistochemistry, which is basically the confirming the protein expression. And then they looked at the T cell receptor sequencing. So what that means is that they looked at the presence of immune cells, and they looked at the T cell receptors important in understanding whether the immune cell actually recognizes the protein that comes from the cancer. And as you can see in this slide here, TCR clonality, it just means like there are different types of T cell receptors, meaning that they had a variety to recognize different proteins coming from the cancer, and that was much higher in leiomyosarcoma compared to other tumor types. And the frequency is basically the abundance of these different T cell receptor types. And again, it was higher in the leiomyosarcoma compared to other types. Again, this is very small numbers, so it's not like a huge randomized trial or anything like that, but you know, it is still important in kind of having an understanding of the immune landscape. So in addition to T cells, which has been important in melanoma, lung cancer, the more we study the immune landscape in sarcoma, especially leiomyosarcoma, we found out that actually macrophages, which is another type of immune cell that's found in the immune microenvironment in the tumor, is important in sarcoma, including leiomyosarcoma. So this is a study where they've looked at the macrophage infiltration and T cell infiltration, so two different immune cells in leiomyosarcomas. And here you can see that actually there was a significant, CD63, which is a macrophage infiltration in leiomyosarcoma, and that infiltration level got higher as the tumor was getting more aggressive, so there was a direct correlation. And then they haven't given any treatment to these patients, but they basically looked at the infiltration level and they looked at clinical outcomes. So how long did these patients survive, and what was the time to the disease progressing. And as you can see, there was a direct correlation with the level of macrophage infiltration in the tumor and survival and the disease progressing. So what does it mean? I mean, can we use it as a predictive marker? I don't think so, but I think this is important in highlighting the fact that actually maybe there is another component of immune system in sarcoma that could be critical in understanding the disease and more importantly, developing a new therapy that targets a different type of immune cell that's different to what's being used for other cancers at the moment. And this is just a confirmation of it in with immunohistochemistry at protein level. So I think I've already just mentioned that. This is a summary of what I was talking.
Go back.
Yeah, sorry. Basically, this is just a summary of what I was just saying. So the CD6, so the macrophage infiltration was higher in the leiomyosarcoma cell, a tumor. And then this is a very similar study looking at the macrophage infiltration and IDO pathway, which is basically an enzyme that's expressed or produced by the immune cells that has an inhibitory effect on the function of the immune cells. And these patients were treated with chemotherapy and immunotherapy. And here we can see, so basically they looked at the clinical outcomes. Again, there wasn't much of a response in most of the tumors, including leiomyosarcoma. And they looked at PD-L1 expression, which is basically a protein, as I mentioned before, expressed both in tumor cells and immune cells. So there was only one leiomyosarcoma patient in this. So it was high in both the tumor cells and immune cells. But and then they also looked at this production of this enzyme IDO on the macrophages, the immune cells, and it was high in the leiomyosarcoma patients, so 73%. It was highest. So again, what does it mean? So because the clinical outcome was negative, it could be associated with, as with a lack of response or resistance to immunotherapy. But again, this is a very kind of correlation that we don't really understand the mechanism of, so we can't really come to any conclusions. But again, it's something that could be looked at in the future. I think I'll just move on in the interest of time, because this is just a picture of what they have looked at. And finally, I want to talk about B cells. Again, this is another type of immune cell that has kind of come to picture in sarcoma over the last couple of years. So there was a study by Friedman et al. And his colleagues, where they looked at the genomics of different different sarcoma subtypes, including leiomyosarcoma, and they've classified the tumors based on the immune infiltration, and they've graded them into immune desert, so as a lack of immune infiltration, and immune hot, so very kind of infiltrated with immune cells. And then they looked at the components of this immune infiltration, and they've then correlated that with clinical outcome. And they also looked at whether certain types of tumors and whether having certain size or histological subtype or the anatomical position or anatomical location of the tumor actually makes a difference in terms of clinical outcome. They haven't seen any, but what they've seen is that so tertiary lymphoid structures, which is you can think about it as a group of immune cells in the tumor, which is very dominant, which predominantly has B cells in addition to T cells and macrophages, actually played an important role in determining clinical outcome. It was, I shouldn't say determining, but it was associated with better clinical outcome, including leiomyosarcoma. But so this is so basically this part of the study was used the cohort of patients from the SARC-28 study, which I have mentioned previously, and sorry, let me go back. Although some patients were responding and there was association with presence of tertiary lymphoid structures, if you look at this graph, unfortunately most of the responding patients were UPS patients. So leiomyosarcoma was mostly in the progressing group. So what's the relevance of all of this? So I've talked to you about several kind of studies that looked at the immune microenvironment, but how is this relevant and what does that mean and what else can we do? So far, everything that I've talked to you about is focusing on pembrolizumab, a PD-1 antibody, and we're looking at mainly T cells or macrophages. But actually, this is what the cancer microenvironment looks like. So you've got your tumor, you've got your T cells, you've got your macrophages, and there's a whole load of factors in that microenvironment, including other immune cells that I haven't even mentioned today. There are other kind of chemicals floating around secreted by the tumor itself, by the immune cells. So actually, and so far what we've been doing in sarcoma is taking an immunotherapy that has successfully worked in other kind of cancer types, and just try to recycle it in sarcoma rather than really having a better understanding of the immune landscape and trying to, in a clever way, target what the problem is, because we don't really know what the problem is so far. And this is just to show that. So if you think about, I've just mentioned the immunotherapy we have so far has been using an antibody to block PD-1 or PD-L1 or CTLA-4. But this just shows all the other potential targets that could be used to develop drugs to have a successful response to immunotherapy. So it's actually what we know so far and we have done so far is kind of a drop in an ocean, which is very limited, especially for sarcoma. So going forward, what can we do? So I think having an understanding of what we have in leiomyosarcoma tumor microenvironment is important. So far we know that yes, T cells are there, but are they functional? Are they really recognizing the tumor? If they're not, what is it that's preventing it from happening? I think that's really important. So we've seen that. So that we see a lot of macrophages in leiomyosarcoma. So what's their function? How can they be targeted? And understanding the other immune cells, maybe their interaction with macrophages or T cells, I think is quite important. But how can we do that? So we are a bit limited in running huge randomized controlled clinical trials or having a lot of samples to actually understand this. So I think it's really important to make use of the best use of what we have. So all the tumor samples coming out from surgeries, all the tumor samples that are coming from biopsies. I think it's important to have a system in place to make good use of that tissue so that we understand the disease better. Tumor explants, so that's a relatively new concept in cancer. There are a lot of successful studies in lung cancer where they basically grow a chunk of tumor in the lab and you can use it. It's kind of having a live mini trial in a petri dish. So you can use it to see what happens live in the tumor and what happens when you draw certain drugs in the tumor. So you don't have to necessarily have 20 patients and give it to 20 patients in a trial. If you're limited in doing that, like we are in leiomyosarcoma and other types of sarcoma, you can make best use of the tissue you have to kind of see if you can have some benefits in the lab environment first and use that to then justify having a bigger trial.
What is that called again?
Tumor explants.
Explants?
Okay. So I think I've already kind of summarized what I was going to say.
Great.
So any questions? Yes.
When you were talking earlier on, you were talking about the great advances in immunotherapy with melanoma and lung.
Yeah.
When you showed the great picture of the tumour with kind of all the crazy stuff going around on the one before this one, that just shows, oh God, where do you start and which one are you going for? But did they just get lucky in melanoma or lung, or is it just because they've got so much investment because they're a more common cancer?
I think it's both.
Okay. So is it a bit of luck
I shouldn't say luck really. Though I think
their picture wouldn't be as complicated as that.
I think it's so the melanoma study, the initial drug was CTLA-4 with Gemalacin in the US, and it was the positive finding was in mice, but obviously there was a lot of investment in that So yes, I think it's a bit of a chicken and egg. So it wasn't necessarily luck as per se, but there was a lot of, it was an area of research that was, I think, probably better funded and had more interest than sarcoma. And then obviously when it's all exploded, became very successful, then it just attracted more and more interest and funding.
What I understand is that most of the research thinking is going into the direction of thinking about microenvironments for sarcoma. But my question is if you've had your tumour.
Can you hold the microphone?
Yeah, sorry. My question is if you've had your tumour tested for genetic defects, is there any link between that and that?
So we don't know, but there could be, because the genetic defects could be changing the tumour and tumour microenvironment, and we don't know what kind of immune cells that would kind of attract to the immune sites. So, but I mean, as far as I know, we don't have any.
For Leiomyosarcoma, no, we don't.
Okay, thank you.
It seems like one of the problems is getting tissue to test and patients to test. Is it possible? Can you make? I mean, the tumour explant seemed like a good idea, but can you make LMS immortalised cell lines? Is that possible?
You can have immortalised cell lines, but I think the immortalised cell lines, because they go through so many divisions, so many cycles, then it's quite difficult to tell if they're really, by the end of it, really representative of the actual tumour itself, because of all the change they go through.
Is there a system whereby people having surgery, I mean, I noticed presumably a lot of this is done on paraffin-embedded tissue.
Yeah.
I mean, is there a system where tumour samples can automatically go to some central repository for research? It seems like you want to. It's really useful material.
Yeah, it is really.
Yeah, and Paul will talk a little bit more about that later on. But I think that's a sort of crucial point, basically, about improving the understanding of the biology of these diseases. And Paul and other colleagues around the UK and Europe have been working on a project to try and look at treatment in the preoperative setting, and Paul can vouch that we've sat through so many meetings in terms of just getting the legal aspects, the bureaucratic aspects, the compliance aspects sorted out, of working with colleagues in other institutions to try and get as much information as possible. But there's a lot of work that goes on behind the scenes to get something like that sorted out, and even getting a clinical trial in Leiomyosarcoma set up. There's a lot of work that goes on behind the scenes, and in a way, I suppose the point I'm trying to make is it would be great if we could make that simpler, because that's what patients want. They want us to look at the tumours and try and better understand what treatments will work, what treatments won't work. But we have to go through the hoops of the sort of legal and bureaucratic system that's in place.
I want to understand, do you work with your colleagues in the United States so that your research projects are not duplicating each other? So that you're moving forward, so that we're not recreating the wheel?
So the short answer to that is yes.
Okay.
So I think that's the only way that we're going to improve things, and it's really, really important. But I'd say that again, all of the sort of bureaucracy sometimes makes it challenging, but we definitely work with colleagues in Europe and in the United States whenever we can, and it's critical.
I guess just to add to that, yes, we do work very closely with our colleagues, not just in the US, but in Asia and Australia as well. But there is also, duplication. We try to avoid duplication in research, as it has been very nicely shown by both Robin and Emily. There is also an issue of reproducibility, right? So you don't want to just see a signal in one cohort and then not be able to reproduce it in another group of patients. So what we also want to see is, in multiple groups of patients, we are seeing the same effect. So there's no false positive, and we run phase 3 trials that ultimately fail, right? So I think there is a little bit of duplication is not always a bad thing, but we rest assured we do work very closely with our colleagues, both on the clinical side but also on the research side.
I think just another thing to add was that we really want to, as we continue to go forward and strengthen research, that actually we can continue to strengthen those collaborations between the UK and all across the world, even with LMSDR, for example.
Can every lab look for this immunology cells and so, or you need expert labs?
Well, I think you need to have an immunologist, because it's not only, technically you can have a technician to kind of, give you a result, but it's really, first of all, having that setup is important to be able to do the experiments, and also it's really key to have an immunologist to be able to make sense of it and then to be able to identify, so what's next. So, in an experiment in a lab, you get a lot of data, and it's important to kind of be able to tease out, that's the key information, that's what we need to focus on, because, especially with limited funds and everything else, you have to be really crystal clear in your head what's important, what's not important.
And you need fresh tumor cells, yes? So you can do it only after a surgery or so?
So for different types of research, we use different types of tissue. For genomics, you can use archived tissue, but for immunology, especially if you want to kind of do more functional studies like explants, test new drugs, you do need fresh tissue. For an immunologist, fresh tissue is like gold.
More an observation than a question, but he's mentioned several times that unfortunately this trial of these two drug combination work, or this was negative, unfortunately this. It's not necessarily the end of the world. You're adding to the sum of your knowledge overall, and you can eliminate these from future trials, or it doesn't work. There's WD-40, the product. We're aware of this. It stands for water displacement 40. It was the 40th version of the water displacement product the guy was trying to create. He couldn't come up with a more catchy name, so he called it WD-40. You'll get there in the end, but it's just... So I'm not trying to say is that the negative thing is not as negative as it comes across.
I think what you said is really key. Before I gave the talk, I think I really wanted to make sure that I don't stand up here and kind of create a negative picture, because that's not the case. I think there has been a lot of advancement in the metastatic setting especially, but it's just highlighting that. I think for me the key thing was to highlight that what we have used in sarcoma so far is based on research on other types of cancer, because our research needs more support. So we need to have a better understanding in sarcoma to be able to develop all these new drugs, because there's a lot of potential signal from the studies that have been done so far, but we just have to focus on sarcoma specifically rather than trying to recycle what's been used, developed for other cancers.
I think that's a great point, and I think one of the things for leiomyosarcoma in particular, in the metastatic setting, that we've got a lot of treatments that we can offer patients compared to other sarcoma subtypes. There are lots of treatments that can be offered. one of the things, though, I think, coming back to that point, that I think leiomyosarcoma encompasses a range of different types of cancer that we're only just trying to, or we're only just beginning to understand. And overall, these trials may be negative, but there's probably a subgroup of patients with leiomyosarcoma within those trials that benefit from a particular treatment, and that's what we need to try and get better at doing, is to identify why some people do really well on a particular treatment and others don't do so well, and so that we can select patients for individual treatments. But your point's really, really well taken, and I think there's definitely a positive in terms of many more treatments available for leiomyosarcoma compared to 10 years ago when Sharon and I last saw each other in San Francisco.
Also Susie has a question over there.
I just wondered, do you have an international tumor or tissue bank that you could use, or could that be the future? Because I think when this cancer is so rare, you need to collaborate with all the countries that you can.
Yeah, again, that's a fantastic point, and Sharon mentioned the Count Me In project, and again, I think in Europe there are more sort of legal bureaucratic hurdles to overcome in terms of doing that sort of overarching
but
project.
But it get harder when you're not a part of the EU anymore?
This is a conversation for afterwards. I keep promising my wife that I'll never talk about politics, and although Susie and I had a little chat about American politics earlier on.
Yes, because you did mention like laws and legislation.
But it's more to do with the confidentiality laws and the transfer of material. So I don't think it's to do with necessarily with the interaction between the UK and the European Union. It's just sort of transfer of
data.
Yeah. But that would be great, and that's a really good thing to aim for, because that's what everybody wants, basically.
So I think we're going to have Susie one more question, and I actually have one more question as well. So two last questions, but we are slightly behind into our break at the moment. You sure?
Susie will ask me a political question in the break.
So I just had a question of, if you had a magic bucket of money to do something in this space now, what would you want to do with it?
Do you want me? I think M&A's highlighted it in terms of trying to better understand leiomyosarcoma in terms of what we can target and better understand why the disease is so aggressive in some people and not aggressive in others. But if we could analyse somebody's tumour and say, well, of course, in this case we need to use X, Y, and Z, that would be fantastic. So if we could do a whole panel of tests and just say, well, we need to treat with these drugs rather than just the sort of, well, let's try this and see approach. I mean, M&A, Andrea, Ed, Paul, you probably got, what are your thoughts?
Very long bucket list.
That would be, as an oncologist, that would be my dream, that I can, somebody walks into clinic and I can just say, well, this is the best treatment for you. We know the biology of your tumour, and we can select a treatment specifically for you.
That's great. Thank you very much. Don't worry, those questions are coming to the other speakers as well. But just wanted to say thank you very much to our speakers for this morning. And we're going to head into our break for tea and coffee outside. And we'll probably join back at about 11:10. But before we finish, just want to say thank you. We have a little something for you both to say thank you very much. And can we just give it A round of applause to say thank you.